Good evening and welcome to the December 11th meeting of the Board of Directors of Washington Hospital. I invite you all to stand and join me in the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Dee, if you take the roll for us, please.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Wallace.
Present.
Director Eapen.
Present.
Director Yee. Present.
All here and accounted for. It's good to have that way. Our first item of business tonight is the election of officers of the board for the next year. It's traditional that we have this election in the first board meeting of December. So I would ask for any nominations from the board at this point.
Mr. President, I move that we accept the following slate of officers for the remainder of this year in 2020. President, Mr. Mike Wallace. First Vice President, Dr. William Nicholson. Second Vice President, myself, Jeannie Yee. Treasurer, Dr. Jacob Eapen. And Secretary would be you, Dr. Stewart. Last but not least.
Thank you, Jeannie.
I'll second that motion.
We have a second. Is there any discussion on that from the board? Any questions, discussion? Thank you. Then we're ready to take a vote on that. Dee?
Director Stewart.
Aye.
Director Nicholson.
Aye.
Director Wallace.
Aye.
Director Eapen.
Aye.
Director Yee.
Aye.
Good. So for just a minute, excuse us for just a minute as we change some chairs. Mr. Wallace has reminded me I need to take my water with me.
I told Dr. Stewart I've been battling a bad cold and I didn't want to get anything further than I already had.
Thank you, Dee.
And I want to take this opportunity to really thank and acknowledge Dr. Stewart for your leadership during last year. There was a lot of things that occurred during the year, and I think you did an excellent job in the role as board president.
Thank you. Thank you very much.
Okay, with that being said, we're going to move on to the consent calendar. The consent calendar consists of those items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Okay, may I have a motion to approve the consent calendar items A through H?
So moved.
Second.
Dee, please.
Director Wallace.
Aye.
Director Nicholson.
Aye.
Director Yee.
Aye.
Director Eapen.
Aye.
Director Stewart.
Aye.
Okay, well, the consent items are approved. At this point, we're going to go to the communications. Is there anyone that wants to make an oral communication to the board? Are there any?
There are none.
Okay, we're going to move on to the communication for the medical staff, Dr. Kilbrew.
Thank you. We have several new appointments. We have Dr. Abram Basra, Emergency Medicine, Provisional Active, Dr. John Pastoris, Orthopedic Surgery, Dr. Q Nguyen, Emergency Medicine, Maria Nunez, Nurse Practitioner, Kalgi Parmar, Dr. Kalgi Parmar, Podiatry, Dr. Sarah Schechter, Pediatric Hospitalist, Dr. Sadia Shamim, Anesthesiology, Dr. Catalina Villa, Psychiatry, and these are all initial 2-year appointments. We have no 1-year appointments. Temporary privileges were requested by Dr. John Kosturas, Orthopedics, Dr. Queen Nguyen, Emergency Medicine, Dr. Kalgi Palmer, Podiatry, Dr. Sarah Schechter, Pediatric Hospitalist, Dr. Sadia Shamim, Anesthesiology, and Dr. Catalina Villa, Psychiatry. Waiver request, we have Dr. Jennifer Chan, Thoracic Surgery, asking for an extension of proctorship, Dr. Sarah Karamalu, Podiatry, also asking for an extension of proctorship, and Dr. Lynn Wong, Oral Maxillofacial Surgery for extension of proctorship. We have 2-year reappointments, Dr. Basil Besh, Orthopedic Surgery, Ambulatory, Stephanie Carnes, Physician Assistant for Dr. Saw, Allied Health, Dr. Gurpreet Shahal, Internal Medicine Hospitalist, Dr. Mandeep Chawla, Internal Medicine Hospitalist, Dr. Gail Dressler, Family Medicine, Dr. Joanne Falkenberg, Family Medicine, Dr. Ashfin Gayami, Family Medicine, Dr. Michael Golden, Physical Medicine and Rehabilitation, Dr. James Hartford, Orthopedic Surgery, Dr. Shashank Jolly, Cardiothoracic Surgery, Dr. Thomas Kelly, Telemedicine Radiology, Dr. Daniel Kennedy, Intensivist Critical Care, Dr. Mark Koransky, General Surgery, Dr. Pramod Krishnamurthy, Pulmonary Critical Care, Dr. Tarun Kumar, Family Medicine, Dr. Richard Lee, Internal Medicine, Dr. David Levin, Pathology, Dr. Danny McCarthy, Telemedicine Radiology, Meenal Mistry, Physician Assistant for Dr. Saw, Dr. Hui Haikam Fan, Pediatric Hospitalist, Dr. Nahid Rostami, Neonatology, Dr. Mark Saleh, Urology, Dr. Lindsay Watson, Pediatrics. 1-year reappointment, we have Dr. Armindo Davila, Family Medicine, Dr. John Dearborn, Orthopedic Surgery, Dr. Surjit Mahal, Family Medicine, Dr. John Mahegan, Vascular Surgery. Transfer in staff category, we have Dr. Albert Brooks, who is moving from administrative to honorary. Dr. Yoshiro Oki, Hematology Oncology, moving from provisional active to active. Completion of proctoring prior to eligibility for advancement in staff category, we have Dr. Brian Beal, Emergency Medicine, Dr. Merzan Zamali, Internal Medicine Hospitalist, Dr. Julia Lee, Telemedicine Radiology, Dr. Kwei So, Internal Medicine Hospitalist. Completion of proctoring and advancement in staff category, we have Dr. Jennifer Chan, Thoracic Surgery, Dr. Lata Sunil Kumar, Internal Medicine Hospitalist, Dr. Nathan Van Dyke, Emergency Medicine. Extension of proctorship and the provisional category, we have Dr. Jennifer Chan, Thoracic Surgery, Dr. Sarah Karamalu, Podiatry, and Dr. Lynn Wong, Oral Maxillofacial Surgery. New privilege requests, we have Dr. Tarun Kumar, Family Medicine. Deletion of privileges, we have Dr. John Mahegan, Vascular Surgery. Conflict of interest statement was updated by Dr. Basil Besh, Orthopedic Surgery, Dr. Albert Brooks, OBGYN, Dr. Michael Golden, Physical Medicine Rehabilitation, Dr. Mark Saleh, Urology. Leave of absence, Dr. Barry Rose, Orthopedic Surgery. Withdrawal of application, Kulbinder Hans, Nurse Practitioner. Relinquishment of privileges, Dr. Bhupinder Bandari, Gastroenterology, Dr. Andre Gay, Orthopedics, Dr. Karishmasi Reynolds, Orthopedics, Dr. Sukhwinder Goni Sandhu, Gastroenterology. And finally, resignations, Dr. Apollinar Gakoti, Internal Medicine, and Dr. Sheshasri Sheshadri, Pediatrics.
Wow, that was a lot.
Yes, it was a busy.
Just that scene. Yeah. Thank you. Can I have a motion for approval of the credentialing action items?
So moved.
Second? Anyone?
Second.
Okay, Dee?
Director Wallace,
Aye.
Director Nicholson,
Aye.
Director Yee,
Aye.
Director Epen,
Aye.
Director Stewart.
Aye.
Okay, that motion passes. Thank you. All right, Kimberly.
Right.
Yeah.
This evening, we have a report on the economic impact of Washington Hospital Healthcare System. If you remember, in 2011, we actually did a report to the community, and we've asked Economic and Planning Systems, Inc. to do an update for us this evening. We've been working with Ben Sigmund, and he is here this evening to present, and he's an economist with 20 years of experience providing consulting services to public, private, and institutional and not-for-profit clients. His expertise includes real estate, municipal finance, and regional economics. Ben works throughout the United States and abroad. Recent high-profile projects include economic studies for California Strategic Growth Council, the University of California System, the East Bay Economic Development Alliance, and the East Bay Regional Park District. Ben holds a Bachelor of Arts degree in economics from Colby College and a Master of Science degree from the University of California, Davis. And we're going to begin with Donald Pipkin, who you know, our Chief of Strategic Management. He's going to give a short introduction before Ben launches into the economic report.
Good evening. So I just want to take a brief moment to thank Ben and the team at Economic and Planning Systems for all the work they did to complete this report, and also to our CEO and leadership team for all the support they provided with data and information and clarification to complete this analysis. I just briefly wanted to introduce what an economic impact report is. So, we typically review the importance of the high quality health care that the district provides to district residents. But it's also important for us to understand the important role that the district plays in the economic vitality of the district and the region in general. So Ben will get into additional detail, but essentially, we look at the economic impacts from a number of different areas, including job creation, and this stems from the spending that the district performs through operations, but also through construction, such as the opening of the Morris Hyman Critical Care Pavilion. We also look at the importance that the leadership of the healthcare district in providing high-quality healthcare services in a specific area. Also, the impact that charity care has on our district residents, and also the great work that our volunteer services department does to support the patients here in the healthcare system. And then finally, we look at the community benefits from specific programs, partnerships with nonprofit organizations, et cetera. So I just wanted to frame the report, and I think with that, I'm going to invite Ben on up to get into the detail.
Good evening, honorable board members. Pleasure to be here tonight to present to you this update to our economic impact work. I can make this as conversational as possible, but I'll just keep rolling through until you all start jumping in. So just the agenda for the talk tonight, we're going to provide a little bit of the economic context, population and jobs in the region. I'm going to give an overview of your system. We're going to get straight into dollar estimates of economic impact. That's spending in the local and regional economy. And then we're going to talk about some of the softer contributions that the healthcare system makes here in Alameda County in the East Bay. So when we talk about economic impacts, Don introduced this nicely, but to put a little bit of a finer point on it, on the left we have our primary economic impacts. These are what you see very traditionally economists doing, looking at spending in the region, the jobs that spending supports, and how that spending recirculates, creating additional jobs and economic activity locally, regionally, and even nationally. We tend to, as economists, break down these multiplier effects or ripple effects as indirect and induced. It's kind of technical, but the indirect piece is essentially business-to-business transactions, and the induced piece is household spending. We capture both. We use a economic model called IMPLAN, which is maintained nationally and is fed with various federal sources of data. The Bureau of Labor Statistics, Bureau of Economic Analysis, and Census Bureau, for instance, all pour data into these models. They're updated annually. So we're looking at a 2018 model. And then on the softer side, qualitative and quantitative assessment of the economic and really social impacts that the institution has here in the region. And as Don mentioned, the medical leadership, the charity contributions, and community benefits, and we'll talk about those over the course of the next few minutes here. I know you're very familiar with it already. The district itself here kind of outlined in yellow, but at 360,000 people, very significant corner of Alameda County, and actually very economically important. It's about 20% of the population, but 30% of the economic spending that occurs here. 30% is district versus the county overall. So you sort of have this outsized economic engine relative to population. And it comes from the advanced manufacturing that's happening locally, but also healthcare in the district as well. We run all of our numbers off your fiscal year report. So everything kind of dovetails with the finances of the healthcare system. Operating revenue over $500 million, employment over 2,200 payroll jobs. It's the third largest employer in Fremont. The employee compensation over about 130,000 each, $290 million total payroll here in 2018. And then the charity care, we estimated about $158 million. I'll show you a detailed breakdown of that in a minute. But that includes both the sort of unreimbursed care costs as well as some of the community programs that you all are pouring important dollars into. So here's kind of the punchline. If we were going to put this on the radio, in Alameda County, you're responsible for 3,400 jobs and almost $750 million of economic impact. It's a good size impact given what you're doing. What that doesn't capture is quality. This is just a quantity measure. You're a big system with a lot of spending, and it translates locally and regionally. So within the district, it's 3,000 jobs and $670 million, and that includes that ripple or multiplier effect that I was describing a moment ago. I did want to show you, because it's interesting to us and I think interesting to a lot of the staff we were working with when we did some of the changes since our last study. In terms of impact in the district, we're up a bit. Jobs are kind of flat. Spending here in the district up a bit. But in Alameda County, a slight decline. And we wanted to really peel back the onion and understand why that is. And so I have a couple of pretty good explanations for you. What we see is that people are living farther away, and they're driving to work here. So where it had been about 5 out of 10 employees were living in the district, we're down to 4 out of 10 employees living in the district now. And more importantly, the reason we see that effect in Alameda County had been 9 out of 10 almost employees living in Alameda County, and their household spending rippling through the economy here. Now 7 out of 10. So that shift in where people live is really affecting the regional economic impact. It's countered to some degree by the local spending on services and goods. So you have increased your local spending. 1 out of 10 of your vendors is here in the district, and that local spending has increased. So that offset the effect to some degree. So we thought those were kind of important factors in some of the shifting landscape that we wanted to bring to your attention. And it's not you, it's your context, right? It's the high cost of living in the Bay Area is forcing people to drive farther. And you all are doing a great job, I think, countering that with increasing your local spending. So let's talk about construction. We were talking a lot about operations there. You all have had a tremendous capital campaign and investment in real estate assets here on campus. In particular, the Critical Care Pavilion. In fiscal year 18, it was over $50 million in local construction spending. That, with the ripple effect, was about $73 million in spending in Alameda County, supporting 375 jobs last year. So that pretty meaningful contribution to the construction industry. Over the life of the pavilion project, construction went on for almost 10 years, $350 million price tag. There was quite a bit of leakage. We think about $270 million stayed in Alameda County, and with the ripple effect, we generated about $340 million countywide. 200 jobs here on average any given day you were building that project, and at its peak, nearly 500 jobs, 500 people working here building that critical care pavilion. So very important project in terms of sustaining construction activity, sustaining the construction industry in this part of the East Bay. I'm going to transition now to some of the softer aspects of the economic impact analysis. First and foremost, we want to recognize that when people are healthy, they're productive. And so with a mission of health, you're in meeting that mission, you're creating economic activity, economic benefit. You do so through leadership in medical services. You all, in terms of joint replacement, cancer care, cardiac care, stroke care, neuroscience work, and the emergency services, you're doing an excellent job, not only keeping people healthy, but setting an example for other healthcare institutions in the region and nationally in these areas. The partnership with UCSF is new since we did this last time, and this is a great step in terms of essentially reinforcing and reinvigorating your leadership in some of these key areas: cancer care, pediatric services. In addition to sort of buttressing your existing strengths, this partnership has allowed for growth in some areas as well, to provide services that you hadn't before or at a greater depth than you had before. Coming back to the critical care pavilion, because it is so impressive and meaningful here, it's got the, in addition to those construction impacts, it's providing a very important aspect of care that hadn't been available before, with an emergency department that's 4 times what it had been, and the potential in the future to be a trauma center. This is an important asset to the health of the community and therefore the economic viability and sustainability here in the district and beyond. Putting a finer point on some of the charity care, this is Medicare and Medi-Cal unreimbursed amounts, and you all cross-subsidize this through your paying customers, but these are very meaningful unreimbursed amounts. So it's about 70% into Medicare and 30% Medi-Cal, and the large majority is coming from your inpatient services, but these are big numbers, $150 million. And this is a point we actually went back and forth with the finance department on, and we believe this to be a conservative estimate. We'd worked on some numbers previously that were a bit higher, and this is sort of double vetted and conservative. Also contributing to the charity care perspective is the volunteering. You have such a strong volunteer program here at Washington Hospital, and it's thousands and thousands of hours, over 30,000 hours in 2018 volunteer time. And this is value with no cost, right? You're enhancing these folks who are so critically providing these services. They're enhancing the richness of the care experience at no cost. So it's really a benefit to the patients and to the community. Moving on, let's look at some of the programs you all fund that do kind of enrich the community, putting a dollar amount on it here, almost $3 million in fiscal year 18, providing health education through the TV channel, special women's services at the Women's Center, the WOW van, which is active locally here, as well as in emergency response capacity throughout the region. So just an amazing array of kind of not for fee services that keep people healthy and keep them productive in the economy. You support a number of not-for-profits. Here are a few. This support comes, in this case, through leases that are either free or essentially real estate that's not leased at its full cost. So we've got a number of entities that take advantage of that. What's not shown up here, you also have a simulation lab that's made available to schools and different educational programs for their use at no cost. And so we looked at the potential market value of some of these leases versus the actual rates paid, and we think that you basically gave away $360,000 in potential rent last year to entities like One Child Save, Bawar, and Hers. And then I'm going to conclude on a kind of high note. You all are sponsors of some really great programs. Here are just a few examples, and you can see the note down at the bottom. There's 60 plus kind of programs that you all are sponsoring every year, and this has a major contribution to quality of life in Fremont and in the East Bay, and keeping people happy, keeping them healthy is keeping them economically productive, and this is great stuff that you do. So with that, I'm happy to take any questions or discuss any of the topics I put in front of you tonight. Thank you.
Thank you. Any questions from anyone? No, very impressive report, though. So
Okay.
Thank you, Ben. Thank you very much.
Appreciate it.
Yep. All right, we're going to move to the Service League report. Ruth?
Hi, good evening.
Good evening.
I would just like to report that in our last month, we were contacted by a local Girl Scout troop, and they wanted to supply our patients with scarves. So we met with them, talked to them, gave them our criteria for the scarves. And last week they came in, they donated 60 scarves to be given to our patients to help keep them warm and to provide comfort to them. They were very excited and chipper. There were 18 of them that came to the volunteer services office, and we were able to take some pictures that they were going to use, and our community relations department will use those also. But it was very enlightening, and they were very happy to donate the scarves for our patients for the winter.
Well, it's nice. The shop is doing quite well.
Yes, the gift shop is doing
Gift
well.
shop.
Our sales are going, and we also had our masquerade, and that did really well. Lots of new items and lots of sales, so we're very happy with our fundraising for this year.
Yeah, my wife has made a raid over there. She has zillions of little gifts she's giving away. Yeah.
They're the repeaters that would come and purchase items and then go back to their departments or go back to their wherever they worked, and they would come back the next day and said, I have to come back and get more of these items.
Yeah.
And so it was really nice.
Yeah.
Really nice.
Well,
Thank you.
Thank you, Ruth. Okay, we'll go back to you, Dr. Killaroo.
Thank you. So we have a total of 578 medical staff members, out of which we have 359 active members and another 39 provisional active members.
Okay. Good deal. All right.
All right,
Kimberly?
why don't we start with the overview of our hospital calendar events report?
Past health promotions and outreach events. On Friday, November 15th, Washington Hospital participated in the Business to Business Summit hosted by the Fremont Chamber of Commerce. The event featured a panel discussion with industry experts, including Washington Hospital on business growth with tips on engaging large corporations and securing corporate contracts. More than 35 people attended. On Monday, November 18th, Washington Hospital hosted an ABC7 Town Hall in the Conrad E. Anderson MD Auditorium. The Town Hall was part of ABC7's Building a Better Bay Area series. The event focused on the city of Fremont. The event moderators were ABC7 news anchor Kristen Z and ABC7 news contributor and Chronicle insider Phil Mateer. Panelists included Washington Hospital CEO Kimberly Hartz, City of Fremont Mayor Lily May, City of Fremont Vice Mayor Raj Salwan, Fremont Police Department Captain Sean Washington, and several other community and business leaders. The series included segments aired on ABC7 featuring challenges Fremont faces. On Thursday, November 21st, as part of the Women Empowering Women series, Dr. Victoria Leapart, gynecologist, presented The Art of Relationships. 13 people attended. On Thursday, December 5th, Kimberly Alvari, Director of Food and Clinical Nutrition Services, presented Food is Medicine, Eat for Wellness, Vitality and Longevity. 47 people attended. In support of East Bay Agency for Children, on Tuesday, December 10th, the Washington Hospital management staff donated hundreds of gifts, including bicycles, clothing, and toys to Tri-City area families in need. The families were identified through East Bay Agency for Children. East Bay Agency for Children manages the Healthy Start program at Grimmer Elementary School in Fremont. Upcoming health promotions and community outreach events. On Thursday, January 16th from 7 to 8:30 p.m., as part of the Women Empowering Women series, Dr. Victoria Leapart will present A Happier You in 2020. Bay Area Healthier Together. Washington Hospital's partnership with ABC7 continues to provide health-related information and education through on-air programming and on BayAreaHealthierTogether.com. The featured topic during the month of November was lung health and lung cancer screening, which featured Dr. Jason Chu, pulmonologist and medical director of Respiratory Care Services, plus articles on how to protect your lungs from wildfires and the dangers of smoking. The Washington Hospital Healthcare Foundation Report. For the 24th year, Washington Hospital Healthcare Foundation welcomed in the holiday season with the Trees of Angels celebrations. These tree lightings raise funds for hospice and palliative care. On December 2nd, the foundation partnered with the City of Newark to light the municipal holiday tree at the Silman Center. John Dutra, president of the foundation, made remarks, and the Cougar Choralers from Newark Memorial High School sang for the crowd. On December 4th, the foundation joined with Union City and the Union City Chamber of Commerce to light a holiday tree at City Hall. Kimberly Hartz, Chief Executive Officer of Washington Hospital Healthcare System, made remarks, and the James Logan High School jazz singers set a festive mood for attendees. Trees of Angels will wrap up on December 12th, when we light a holiday tree at the corner of Maury Avenue and Paseo Padre Parkway. Mayor Lily May will be on hand to help throw the switch to light the tree. Before the tree lighting, Santa and Mrs. Claus will sit for pictures with children at the event. The Washington Township Healthcare District Board of Directors report. Washington Township Healthcare District board members attended the Niles Festival of Lights Parade on November 29th, the Newark Chamber of Commerce Holiday Luncheon on December 5th, the Masonic Homes of California Holiday Tree Lighting Ceremony, also on December 5th, and the Bay Area Council's Scouting Breakfast on December 6th. Washington on Wheels, WOW, Mobile Health Clinic. The Washington on Wheels Mobile Health Clinic, WOW, is a mobile medical unit providing quality healthcare services primarily to uninsured and underserved district residents. WOW brings Washington Hospital's commitment to patient-first care to clients throughout the district. During the month of November, WOW served community members at the Fremont Family Resource Center, Bay Area Community Services, BACS, and the Irvington Presbyterian Church located in Fremont. These community partners provide social services to families in need and the homeless population. WOW also provided occupational health services, including influenza vaccines, at Columbus Foods, a producer of fine foods located in Hayward. The total number of community members receiving health care from the Washington on Wheels Mobile Health Clinic during the month of November was 136. Internet and social media marketing. Washington Hospital's website serves as a central source of information. The hospital's employment section was November's most viewed webpage with 27,492 views. Washington Hospital has an active social media presence. Through these channels, we update the community with news on events, services, and patient care. Connecting with our community through social media continues to grow. During November, we continue to have an active presence on social media. Our most popular social media post told the story of a Fremont man with cancer who saluted the care of our UCSF Washington Cancer Center. The story achieved more than 9,000 impressions. Users can find us on Instagram, Twitter, and Facebook at Washington Hosp. In Health, Channel 78. During the month of November, Washington Hospital's cable channel 78 in Health captured new programming, including 2 health and wellness programs titled Advancements in Lung Cancer Detection and Treatment and Anxiety, Stop Negative Thoughts, and the 2019 Diabetes Health Fair. In addition, In Health aired the November Board of Directors meeting. For more information on any of the programs mentioned, visit WHHS.com or call 800-963-7070, and please follow us on Facebook, Twitter, Instagram, LinkedIn, and YouTube.
All right, it is also my pleasure to introduce the Employee of the Month for December, and it's Ayale Haraboro, who is a certified nurse assistant in medical imaging. Ayale was raised in Ethiopia, where he taught geography. Though being a teacher was a good experience, when his mother became ill, he realized that working in healthcare is a special calling. After going back to school, he joined the Washington Hospital family as a certified nursing assistant in 2017, and the following year joined the medical imaging team. Ayale transports patients and understands that they may be feeling anxious and may also be experiencing some pain or discomfort. He introduces himself to each patient and does his best to put them at ease. While caring for a patient, he recalls the apprehension he felt leaving his mother in the care of others and vows to bring respect and a loving energy to each transport. Ayala embraces the patient-first ethic on a daily basis. Comments such as, "I can't help you right now, I'm on break," or "that's not my job," are not a part of his vocabulary or work ethic. He is the ultimate team player. Raju Thiara, technical manager of medical imaging, says, "The medical imaging team is fortunate to work with such a wonderful person and an excellent team member." When not at Washington Hospital, Ayala enjoys playing guitar with his wife and his 5-year-old daughter. Though he has been with Washington Hospital a relatively short time, he has contributed significantly to his work environment and to the benefit of our patients. He is our December Employee of the Month.
Okay, thank you.
Yep.
Okay, we're going to move on now to the lean report.
Right. So this evening we have the lean report linking strategy to organizational improvement. And unfortunately, Dr. Kirkjohn is not able to make it this evening. But Donald Pipkin will be doing an introduction, and then he is joined by John Boyko, who is our KPO director. And I'm going to just give you a brief overview of John, since he is not presented to the board. John is an industrial engineer who began his career in the automotive aftermarket industry, where he first began his lean journey. As a KPO director at Washington Hospital, John is responsible for putting key principles of the Toyota production system into practice. Some of his main areas of focus include cultivating organizational alignment, establishing purpose-based management practices, and coaching organizational leaders. John is a multi-term appointee by the U.S. Department of Commerce to the Board of Examiners for the Malcolm Baldrige National Quality Award, as well as an NIST Certified Lean Master. Prior to joining Washington, John was a Director of Performance Improvement at Lucile Packard Children's Hospital.
Thank you, Kimberly, and good evening. So the focus of our presentation this evening will be, as Kimberly mentioned, linking the strategic initiatives and priorities of the organization to the operational improvements we perform through Lean or the Toyota production system. So the way we do this is we take the strategic vision of the organization that the board approved, and we work with senior leadership to set that overall vision for improvement across the organization. And then those executive sponsors for those service lines work with process owners or department managers, nursing managers, et cetera, to develop the tactics, identify the necessary resources, and set goals across a service line in general. And then we actually take it one step further, and we say, how does the important work that the frontline staff does with patients or in other operations link back up to the strategy of the organization? So as you recall, we have our strategic map, that is our current strategic plan for the organization. And essentially what we do is we work with executive leadership and management to really link and define specific metrics within those improvement areas of focus. And we link those either to the higher level strategic priorities for the organization. We might link them to specific strategic objectives we have identified for the strategic organization, or link them to those foundational strategic priorities as well. And the way we do this, we consider this line of sight model. We take the strategic map and that vision and those priorities. We have our organization initiatives, and we work with the board and leadership every year to identify those key priorities for that current fiscal year. But then we also work within the departments to work and see how the work they are doing to improve their operations, whether it's in staffing or in quality or in patient care, and how those metrics link back to the strategic vision of the organization. And ultimately, what's really most important is working with frontline staff, those who are caring for our patients, those who are involved in other operations of the organization, to really define how the work they're doing is important and really drives the success of the strategic vision of the organization. So that's just a brief background, and with that, I'll hand it over to John to deliver the rest of the presentation.
Good evening, everyone. All right, so I'm going to just kind of jump into this, and if we look at our line of sight model, I'm going to give you guys a little bit of an example of how this might work with a hypothetical example for our OR. So one of our strategic objectives is increasing financial stability. And if we were to translate that to a divisional level in perioperative, we might see that that could mean increasing surgical volume. So we set a goal for the division. Now, if we zoom down into the OR, what that might mean to the OR specifically, how do we maintain or how do we satisfy the need for surgical volume? It could be because we have a limited amount of rooms, we need to look at how efficiently we're using these rooms. So the OR might say we want to improve our turnaround times. Now, our turnaround times could be wherever they're at. We don't have a number on here because this is just for illustrative purposes. But now we have a goal for the OR. And the key now is to take that goal and translate that into something that we could see within the process, within the turnaround process. So that could be something like ensuring we have equipment availability. And if we are able to see that we have the equipment available, that's a task that will satisfy a goal that will ultimately satisfy a strategic objective. An example of what that looks like in the real world, we have a lot of visualization. So we have visual boards that are set up at various levels of the organization. We see that we have an executive level. We have also on the front line, we have a goal deployment board, which we're calling a leadership visibility board. And then we have a frontline board, which is really driving our daily management. Now, along with that, we have a series of processes, part of which include communication. So we see a lot of daily huddles and weekly huddles. So the objectives or the purpose for everything here is to really kind of give us an idea of how we're doing at a glance. So what's the status of the current state? But it also provides, beyond that, a little bit of a way to have some good communication and some good conversation around what it is that's being done to satisfy that need. So that one of the tools that we use is a lot of executive rounding. And the way the boards are set up, they're conducive to enabling conversation around that. Here's an example of our goal deployment board. And this isn't a real board. This is just for illustrative purposes. But you can see there are 3 basic sections to it. And it helps us clarify the goal, clarify what's going on right now via current state, and then understanding if we have any obstacles to meeting those goals, what we're doing about those obstacles. And then we have a dashboard that shows us where we're at. On the front line, let me just blast through the animations here. On the front line, we focus on daily management systems. So the daily management board is broken down into 3 sections, as you can see there. First section is really all about, on the left, is all about daily readiness. Do we have everything that we need for today to make sure we could execute on our plans? The second section really kind of focuses on a lot of how we're doing with metrics. So you can see that there are some trackers and whatnot. And then the third section to the far right is a way for employees or frontline staff, when they do see the minuscule little blips that we might see that we call barriers, it's a way for them to identify that and to put some type of a suggestion in place to improve that barrier. So it allows that frontline staff to have ownership of the process. So here's an example in our OB department, and you can see that we have a very well populated goal deployment board on the top and a frontline board as well. One thing I'd like to point out on that frontline board is you have that red, yellow, and green section there. That is all of our in-process metrics, and they're relating back up to the top board, which is the goal board. So we could see how the tasks that frontline does relates directly to a strategic objective. It gives them a purpose, essentially, of what they're doing and why. Now, so far we've shown you the top-down communication process. To make this complete, we need to think in terms of a closed-loop system. So the way this works is really a daily corrective process via that frontline daily management system. And with that, we could see that as we incrementally report up, over the course of a year, we satisfy our strategic objectives, or we're somewhere in that range. Some of the benefits, I think the most important one is the top bullet, which talks about engaging staff. A critical component to our success is staff, and the more ownership And the more ability that they have to identify problems and solve problems on the spot, the higher the quality of service that we could provide. Along those lines, we can see the alignment so that we understand priorities. We can understand process at a glance. And it also gives us a good way of communicating and having that conversation that's pointed towards strategic objectives. So where we're at with this process is we've fully rolled out the frontline process, the daily management process. We're in the midst of really developing and rolling out that goal deployment process. So some next steps in that area would be us building a little bit more of a awareness process and getting out to the units and actually putting these boards out. Along with that, we'll probably have to do quite a bit of coaching and just hand-holding. So that's essentially what we have. Any questions?
Any questions? Those examples were really helpful that you gave.
Thank you.
Thank you.
Okay. Night.
All right. The quality report?
All right, so tonight we have Dr. Carmen Akawili, and as you are aware, she's the director of the intensivist program in the intensive care unit here at Washington since 2008. Dr. Akawili graduated from the University of the Philippines and the University of East Memorial Medical Center. She completed her internal medicine residency at St. Barnabas Hospital in New York City. Dr. Akawili did her fellowship in pulmonary critical care at the University of Southern California, Los Angeles County Hospital. She also worked as a clinical specialist at the LA County Tuberculosis Clinic, as well as the urgent care physician at Claude Hudson Clinic from 1988 to 91. Dr. Akawili is board certified in internal medicine and critical care. She's also a fellow of the American College of Chest Physicians and a member of the Society of Critical Care. And she started her private practice in Fremont after fellowship in 1991.
Good evening, everybody. It's been, I guess, 29 years. But I'm still young. I started at 19. Anyway, as you can see, that's where the unit resides now, Maurice Hyman Critical Care Pavilion, second floor. So as background, we started in 2008. I was the only intensivist then. And then by the following year, 2009, we became 24/7. And then in October of 2016, a couple of years later, we made it an intensivist-led ICU. October, really, when all patients are now admitted by the intensivist and they become the attending of record. And of course, we went to the Maurice Hyman Pavilion, November 13, 48-bed ICU, and we continue to do our evidence-based practice and the team approach. So, we fine-tuned our mission to provide the highest quality evidence-based care to all critically ill patients and their families, and we wanted to engage the patient and families in a comprehensive, highly coordinated interdisciplinary care with the human touch. That was suggested by our executive panel. And we continue to have our program goals to identify and improve the condition of deteriorating patients, provide appropriate, reliable, timely care. That's the right care right now. Integrate and engage the patient and family into care always. And create the highly effective team, interprofessional team led by the intensivists. So our structure, basically, it's 2 intensivists per 12-hour shift. It's 24/7. And all the disciplines are presented, not only internal medicine, pulmonary, we have emergency critical care. They're all board certified in critical care, but we have a surgery critical care doc, nephrology, and anesthesia critical care. So it's all the disciplines. So we also have the clinical operations committee, the backbone of our group, which is presented by different directors of the different departments, and our champion, but the ICU nurse manager, LV Balar, helps me out. We co-manage this committee. So in terms of our volume, as you can see, where's the pointer? So that's 2006, and this is a little bit of 2019. There's a decrease in our volume of admission, and that's predicted because there are more now appropriate admission, from 18,000 to 1,005, and it's plateauing at 1,500 maybe, because we're now having more appropriate admissions, and we also have the IMC, intermediate unit, where we send some of our patients that needs more nursing monitoring. And our top 10 diagnosis, it used to be a couple of years ago when I was reporting here, sepsis is our number 1, but as you can see, it's now down to probably number 4. We have more of the cardiac diagnosis and strokes. We still have pneumonia, infectious, but it's changing. And I think it's because we're better with sepsis recognition, so that they don't go to the ICU anymore, they just stay on the floor. So we have used evidence-based practice ever since, and we usually use the Society of Critical Care recommendation, and they're all there for you to see. The A to F bundle, which I probably repeated very much before, you know that already. Pain control is very important, the sepsis protocol, the blood transfusion also protocol, central line, the venous, the ICU readmission initiative, and the palliative care, which now is not only hospital-wide, but we're starting the outpatient. And I'm involved even if I'm in the ICU, because palliative care started in the intensive care unit. So it's kind of like my baby. So for our initiative, which I've told you before, I just want to highlight what has Morris Hyman, the thoughtful building that you all have created, has done to our delirium prevalence. So 8 months before we went to Morris Hyman Pavilion, our delirium prevalence was 12.5, and after it went down to 7.9. We're now in a private room. The sound, is not too much. The patients can sleep better, family can sleep better, so I think that could be the reason. So it was very thoughtful. There are other facilities they have new facilities also like us, but if you look at their ICU, it's not as thoughtfully planned. And you know what I mean, it's just 45 minutes away. The other thing I want to emphasize is the focus on family engagement. As you would know, in our ICU, the family is part of the team. The multidisciplinary team involves the family, and in fact, they're invited to our multidisciplinary rounds. I just want to let you know there are a lot of initiative right now. In fact, we're teaming with Society of Critical Care again to have structured family conference. So that's a 10-month kind of a study. So the other thing that we learned from Kaizen, which you just saw, is the development of the multidisciplinary rounding tool. It's there for you. All the 24 hours data are put into one tool where we have quick access, information within the last 24 hours, description of the standard work, and it's electronic. And this has really improved the efficiency of our rounding and the interdisciplinary communication. Because you look at this rounding tool, it tells you about what's the background of the patient, what are the labs, what happened with pain, what happened with breathing, what happened with choice of sedation, early mobility, all those A to F bundle, that what happened to delirium, it's all in here. So that anybody can look into it, even the doctors. But we use this a lot during our rounding. So it has cut down the hours of rounding from almost 3 hours to almost 1 hour. So for outcomes, our length of stay has continued to be lower than the benchmark. There's some ups. Some of our patients want to stay in Morris Hyman Pavilion more than what they need to. But overall, the trend is still below our national benchmarks. SCCM is about 3.8 days. Now, this one, I want to let you know that we have a bump here. It's a high bump, 5.8 days for the quarter of September. We have been, for the last several years, been on the less than 4 days. And so we drilled down on this, and we're not done yet, but we have noticed that we have sicker patients at that time, patients that that are on tracheostomy but still on mechanical ventilation. And we continue to follow up and probably report on what has happened to this. The good news is October to November, we have only 3.5 to 3 ventilator days, so it's better. So what's the bump? I'm still investigating on that one. It is what it is, and that's how I'm explaining it right now, but I'm still investigating. So the other good news is that our reintubation rates and our unexplained, unplanned extubation are all less than the benchmark. So as you understand, these are all important because if you are liberated from the ventilator, you don't have delirium, you're much better, you can go home earlier, less morbidity. If you have less reintubation, those are all signs of better health, and that means less length of stay and less mortality. So going to the mortality, again, we have maintained a lower rate of mortality. If you look at the National Society of Critical Care benchmark, is about 10 to 29%. So we are on the lower benchmark, around 10 to 14%. The highest here is about 13%. But most of the time, especially in the last several months, we've been on the lower side, less than 10%. So it's been like that for the last couple of years, which is good. Severe sepsis, septic shock. You know that this year we received a reward from health grades. We have 5-star in sepsis. And this shows that we have improved compliance, sepsis compliance with the CMS, which we report to the CMS. So the overall benchmark compliance is only 57%, and we're better than that. And our mortality rate has been within 24 to 30%. There's no benchmark from CMS on this one, but the society, the surviving sepsis is around 30%. But then you cannot compare this because this is not apples to apples. So I just want to let you know that we have improved implementation of our compliance with sepsis, and that's why we have less sepsis diagnosis in ICU. They're being treated more on the floor because they're being recognized earlier. So also we had that readmission initiative. We want to know what's going on with our patients, whether we're sending them out too soon or too slow or things like that. So when this one bumped, I went ahead and take a look at what's the benchmark around again for 2019 and for the last 5 years. There's no national benchmark, but the ones that I read, articles I read, was between 4 to 17%, so around 7% benchmark for readmission. But we're Washington Hospital wants it less than 1%. We're doing too much. But anyway, we're okay. We're there, but we need to probably look into this. So infection prevention, part of it being Morris Hyman, supposedly we have more places to wash our hands, and it's private. So the good news is that we have our critical care ventilator-associated events is less, and our C. diff, like the hospital-wide C. diff, is also less. The other thing that I need explanation to you guys is the critical care infection prevention. We have the MRSA. This is 2018 and 2019, so it's better and it's less than the SEER ratio or the infection ratio. But for Club C, we're going down, but it's still not less than 1. So we're still working on this one. There's a nurse initiative looking into how we clean the areas, the central line area. So we're looking into that. And this is not good because our CAUTI for 2019 went up. So this is our action plan. We reinforce hand hygiene, the timely sharing of data with leadership, reassessment of the catheter insertion and medical necessity, do we really need it, and implementation of this new female urine collection device to reduce the need for catheter use. So I'm glad to tell you this data is up to June 2019. Starting when we started this in late October, we have 0 in ICU for now. So we'll see how it goes. But again, this is one of those that I'm looking into. For patient experience, we're probably a little bit better than the national benchmark, which is around 92, 93%. And This is from 2018, and this is 2019, and we're better in terms of the overall ICU. This is from Press Ganey, overall ICU experience. Also with physician explaining their condition, the friendliness of the nurses. What else? This is also about the how the family is perceiving the patient, the ICU staff. I cannot read it. It's all about the last two are all nurses' experience in terms of their knowledge, experience, and the friendliness. The first two is the physician explaining their illness, and this one is the overall. So for education, we need to encourage and educate our staff, not only the critical care staff, but everybody else. So these educational programs we usually do during May is the advanced care planning, which was well attended. It's for everybody, moderated by Dr. Vandana Sharma. And then we had a very inspiring 2020 vision of CPR. We wanted to also know what's going on outside of the critical care, because you have to have a good pre-hospital system to be able to have better patient results. So we look at that. Dr. Pepe was our guest speaker and really delve into what's the vision, the evolution, the revolution, and novel solutions for CPR. So we're looking into that, and we're partnering with our pre-hospital system, the EMS, with our ER physician and staff. And of course, we still continue to update ourselves with what's going on with sepsis. So these are all for everybody. And we also collaborated with the med-surg, with nursing leadership, to give lectures to the med-surg nurses, because it's very important for them to know what's the recognition of the seriously ill, what is sepsis, what's respiratory failure, and what are the shock states. So this was single-handedly given by Dr. Ted. He's an ER critical care intensivist trained at Stanford. So that's our educational step. And for the next step, we will continue all our practices, expand the interdisciplinary teaching, promote and continue a culture of safety, which is very important. Because we have all these projects, but we sometimes cannot sustain it. So we need to sustain all our good projects. Promote the wellness, especially for our ICU provider, as well as patients and families. This is very important to decrease burnout from us. And of course, design clinical standard work modules to reduce practice variation and continuously improve our care. That's it. Thank you very much. Any question?
Thank you. Any questions? Thank you, Dr.
Thank you.
Ackerwilly. Thank you. Okay, moving right along to the finance report.
We're going to start with Chris Henry.
Yep.
Okay, tonight we will be looking at Washington Hospital's operational and financial performance for October. Jumping right into our operating indicators. Both our average daily census and patient days were off of budget about 5.6%. Our average daily census was 8.6 below budget at 145.1. Patient days were 267 below budget at 4,497. Admissions came in at 950, 17 below the budget of 967. Outpatient observational equivalent days for the month were pretty close to budget, 4 above budget at 175. And our average length of stay based on discharges came in at 4.82. We had budgeted for 4.93 for October. Moving into utilization, case mix index came in almost right on budget at 1.456. We had 123 deliveries in the month that was 6 below budget. Surgical cases were 27 below budget at 371. That included our joint replacement cases that were 9 below budget at 145. Neurosurgical cases came in 4 above budget. That's good. At 30. Cardiac surgical cases came in right on budget at 10. And that leaves our general surgery cases, which were 22 below budget for the month. Cath lab procedures were 133 above budget in October at 489. Our outpatient visits continued to be much higher than budget, 765 above budget at 8,748. And the emergency room came in with 62 visits above budget at 4,284. Quick look at the cath lab activity. Really peripheral vascular at 51% as that product line has continued to grow. Cardiac procedures in the cath lab made up 29% of the activity, with non-vascular IR and interventional radiology coming in at a combined neurointerventional radiology coming in at 18 and 2% respectively. Looking at productivity, our productive FTEs came in 72.5 above the budget at 1,349.1. We had 164.1 non-productive FTEs for the month, leaving us with total FTEs 67.7 above the budget at 1,513.2. As we discussed last month, our full-time equivalents per adjusted occupied bed, which is our productivity indicator, came in about 0.5 above the budget at 6.96. So we had a little bit of difficulty flexing down to the activity in October. Moving into financials, as always, first we'll look at our Governmental Accounting Standards Board presentation. This is the presentation we use for our audited financials. Total patient revenue for the month came in a little over $2.7 million below the budget at $174,138,000. Our deductions from revenue for the month came in a little bit lower than anticipated at 77.56. Had a couple offsets going on there. Actually, our contractual revenues for our insurance-sponsored patients came in a little above budget at 75.74%, about 0.5% higher than we expected. But our provision for bad debt came in below budget by about $1 million, and as a percentage of revenue, lower at 1.82%. We had budgeted for 2.36%, so we got a little relief on our provision for charity and bad debt in the month. So we ended up October with net operating revenue a little bit more than $500,000 below budget at $39,546,000. Operating expenses for the month came in $150,000 above the budget at $40,077,000. Had some offsets going on in there. Our salaries and wages with our higher FTEs came in $892,000 above the budget. We did get some relief in benefits this month. The first quarter we had been seeing some really high insurance claims. Those insurance claims tailed off and actually were below budget in the month by $712,000. Our workers' comp costs were $64,000 below the budget, and those were offset by some higher costs in our pension and post-retirement benefits that resulted as a result of our change in our long-term earnings assumption. Supplies for the month were $191,000 above the budget. That was driven by prosthesis and neuro supplies. Pro fees for the month were $454,000 below budget. We got a lot of offsetting going on here. That was largely driven by medical fees, as the backstop fees that we pay UCSF have really been cut down by those physicians really building their practices. And also our consulting for the month was $65,000 below budget. Really the last big driver in the expenses for the month was our marketing costs, which were about $136,000 below the budget. So we ended up October with an operating bottom line from a GASB perspective showing a $531,000 loss We had expected essentially a break-even budget for the month with a gain of $137,000 in the budget. Non-operating income for the month came in $336,000 above the budget at $295,000. We did have a $184,000 unrealized gain on our investments that drove about half of that. And we are reaping the benefits of the refinancings we did earlier this year on our bond debt. Our interest expense for the month came in about $208,000 lower than we expected in the budget. So we end the month with a total bottom line from a GASB perspective showing about a $236,000 loss against a $96,000 gain in the budget. Moving to our FASB format, this is a Financial Accounting Standards Board presentation, which includes some adjustments that the financial markets might make in the financials you just saw when they review us. The first thing they do is they move our revenue bond interest out of non-operating income where GASB likes it up into operating expenses where FASB likes it. And then they eliminate our tax revenue that supports our GO bonds and the related interest, and that unrealized gain on our investments that I spoke about. So we end up with operating expenses from a FASB perspective almost right on budget at $40,740,000 and an operating loss of about $1,194,000. From a FASB perspective, non-operating income comes in about $73,000 less than budget from FASB at $488,000, and a total bottom line showing a loss of $706,000 against a budgeted loss of $133,000 from a FASB perspective. Now we'll jump to our earnings before interest, taxes, depreciation, and amortization. And again, we look at this to get an idea of how much cash we actually generated in the month to provide for our interest expenses and future capital and other needs. So we look at our operating expenses excluding depreciation, and we show EBITDA at a little over $3.5 million. Likewise, we look, if you move down into the non-operating section, we look at those numbers exclusive of the interest expense that generated almost $2.1 million. So in total, our operating and non-operating activities generated about $5.6 million to provide for debt service and future capital and other needs. So are there any questions on October?
No, go ahead.
All right, before I go over the November statistics, I do want to just say we had a different year than we've had for Novembers in the past. We have not seen the impact of the flu season. So we looked back the last probably 3 years to see, and our patient days and our admissions are down compared to those other years, because we've usually in November have seen at least some of the impact of the flu season. So we're really starting to see that now. So it is much later this year than what we've seen in other years. So just so you sort of know the context of November's numbers. All right, so starting with the gross revenue. Gross revenue of $165 million for November was below budget by $10.8 million and below November of 2018 by $4.2 million. Inpatient gross revenue of $105.7 million was below budget by $16.8 million or 13.7% and $12.8 million below November of 2018. Our outpatient gross revenue of $59.3 million was above budget by $6 million, or 11.3%, and $8.6 million, 16.9% above November of 2018. So you see that on the inpatient. The outpatient services, and you'll see a couple other places, also ED was up, but the inpatient was down. Major drivers of revenue variance. Inpatient days were below budget by 433 or 9.1%, driving room and board revenue down by $2.9 million or 8.5%. Surgical cases were below budget by 46, 11.2%, driving surgical services revenue down $4.5 million, or 12.1%. The lower level of inpatient activity also drove ancillary services revenue below budget by 2.9%, or 3.8, or 2.9 million, or 3.8%. Looking at our key census statistics, average length of stay of 4.68 was below the budget of 4.95. The average length of stay was longer than the November 2018 average length of stay of 4.48. Outpatient observation days were 47, or 30.9% above budget at 199 days. Outpatient observation days were 52, or 35.4% above November of 2018. Average daily census of 144.9 was below the budget of 159.3 by 14.4, 9.1%. And the average daily census was 6.5, or 4.3% below November of 2018. So here you can see the admissions trend. We were below budget by 96, or 9.9%, and admissions for the month were 121, or 12.2% below November's of 2018. Our patient days trend, again, patient days of 4,347 were below budget by 433, or 9.1%, and patient days for the month were 193, or 4.3% below November of 2018. Our surgical trend, also total surgical cases in November of 366 were below budget by 46, or 11.2%, and surgical cases were 36, or 9% below November 2018. Inpatient surgeries were 36, or 14.9% below budget at 206, and 37, or 15.2% below the November 2018 volume. Outpatient surgeries were 10, or 5.9% below budget at 160, but pretty much right on budget compared to November of 2018. Looking at just the breakdown of our surgical activity, our general surgical procedures were below budget by 31, or 13.8%. Our joint replacement surgeries were below budget by 14, or 9.2%. I believe we had a couple of the physicians were out a few days in terms of, so they weren't, our joint replacement and surgeries weren't at budget. We have cardiac surgical procedures were below budget by 2, and neurosurgical procedures were above budget by 1. Looking at our cath lab procedures for November of 405 were 52, or 14.7% above budget, and 62, or 18.1% above November of 2018. Our inpatient cath lab procedures were above budget by 24, or 11.5% at 232, and 35, or 17.8% above November of 2018. And then our outpatient cath lab procedures were above budget by 28, 19.3%, and above the prior year by 27, or 18.5%. Just looking at the breakdown of our cath lab activity, the neurointerventional radiology procedures were below budget by 5. Our cardiac procedures were above budget by 2. Our peripheral vascular procedures were above budget by 25, and our non-vascular interventional radiology procedures were above budget by 30. Looking at our deliveries are down for November. We're at 117, which were below budget by 12, or 9.3%. Our non-ER outpatient visits, our non-emergency outpatient visits of 7,814 were above budget by 700, 9.8%. So you see, we still have a great deal of outpatient volume. That this breaks down to lab visits were above budget by 262, or 9.9%, and 297, or 11.3% above the prior year. X-ray visits were above budget by 146, or 8.4%, but 7 below the prior year. Our OB visits were above budget by 69, or 52.3%, and above the prior year by 69, 50.3%. And this appears to be really a lot of our high-risk moms from our perinatal diagnostic clinic are coming in for stress tests. And so we see that increasing. Also, our infusion center visits were above budget by 49 or 15.2%, and above the prior year by 65 or 21.2%. And lastly, our hyperbaric visits were above budget by 47, 167%, and above the prior year by 49. So that's another area that, with outpatients, we've seen some growth. Looking at our emergency room visits, emergency room visits of 4,238 were above budget by 154 or 3.8%, and were above the same period last year by 188 or 4.6% percent of visits. Now, looking at our productivity, you can see we did focus on looking at controlling our productive FTEs given the lower volume than we usually experience in November. So productive FTEs were below budget by 33.4 or 2.6% at 1,271.3. So non-productive FTEs were above budget by 50.2, 31.3% at 210.7. So again, really, we had the holidays in there, so you see the increase in the non-productive FTEs and really trying to reduce FTEs for this, given the census. So our total FTEs of 1,482 were above budget by 16.8, mainly driven by the non-productive FTEs. And if you look at our productive FTEs per adjusted occupied bed of 5.62, they were below the budget of 5.71 or 1.6%. And then overall, our total FTEs per adjusted occupied bed of 6.55 were above the budget of 6.41 or above by 2.2%. Looking at other operational statistics, November the Washington Outpatient Surgery Center cases were below budget in November by 72 at 507. This was 14 below the November 2018 volume. Also, our clinics, we had budgeted to see some of the flu visits. So our clinic visits of 3,442 were below budget by 211 or 5.8% for the month of November, but 15 above the November 2018 volume. So again, we had estimated greater flu visits that would be coming through the clinics. Looking at our preliminary payer mix, you can see our government-sponsored patient revenue made up 71% of total gross revenue, which is below the budget of 71.5% and the same as last year's percentage. Our HMO revenue was 2.2% of gross revenue, which is below the budget of 2.5%. Our PPO revenue was 25.2% of gross revenue, which is higher than the budget of 23%, and higher than last year's percentage of 23.6%. So hopefully, in terms of looking at our payer mix, higher in PPO revenue. And then lastly, our private pay revenue was 1.6% of gross revenue, which is below the budget of 2.3% and lower than last year's percentage of 3%. Then moving on to the key financial statistics and charity, our days cash on hand for November ended at 168 days, an improvement of 7 days from last month. We did receive some prime funding of $4.3 million, so that helped to drive up those cash days cash on hand. Also, you'll also see with the days of gross revenue and accounts receivable, we're at 57, which was above the prior month of 52. And the main reason for that is really the timing of the holiday. If you remember, Thanksgiving was that last week, so we really had the Thursday and Friday. We didn't see much revenue coming in, and then December started on that Monday. So for us, it was also a short month in terms of collections and also payment of check runs that would happen also that impacted the days cash on hand. So there were 572,841 in charity care applications pending or approved in November. Then lastly, looking at the summary of the homeless patient activity, there were 217 homeless patient encounters in November of 2019. Estimated incremental cost of SB 1152 for the month of November is around $91,000. Our total estimated unreimbursed cost for homeless care for the month of November is $366,000. And our estimated total unreimbursed cost of homeless care for fiscal year 20 year to date is approximately $2.1 million. So again, November was a challenging month from inpatient volume, and again, we're starting to see December's now, our inpatient volume start to creep up now, and we're seeing more of the impact. We'll see how the rest of December goes.
Thank you. Any questions, anyone? Okay.
Okay.
I guess that is it.
I do have one announcement.
Okay.
I have announcements next. I do want to just say that I think, as I mentioned last month, that we have our joint project with UCSF in terms of building an outpatient clinic in the Warm Springs area. As I reported last month, we are in the process of getting the project rezoned. It's in the Warm Springs Innovation District, and it passed through the Planning Council last month, and last night it went to City Council, and it was placed on the consent calendar, so it was unanimously approved through the city. So we're very excited, and I do want to very much thank the city staff for all of their help in this project, and Mark Denage, along with Mayor Lily May and the rest of the city council. They all were very supportive overall of the project, and so we're very excited to move this joint venture with UCSF forward to bring outpatient specialty care and primary care into the Warm Springs Innovation District. So,
Excellent.
thank you.
Okay, before we adjourn to a closed session, I want to just say happy holidays to everyone and have a great 2020. Looking forward to a great year. And so at this point, we're adjourning to a closed session. Okay, we are going to reconvene the open session and announce that there were no reportable actions taken during the closed session. I see that there's no other business, so this meeting is adjourned.